I'm Manoj Karmakar. I'd like to take this opportunity to thank the scientific committee of the Argentinian Society of Anesthesiologists for inviting me to speak at this distinguished meeting. I bring you greetings from Hong Kong. I'm currently based at the Chinese University of Hong Kong and work at the Prince of Wales Hospital, which is one of the two major tertiary centers in Hong Kong. I have no conflict of interest whatsoever relating to this presentation. The objectives of my talk is to discuss with you the applications of ultrasound for central neuroaxial blocks. In the interest of time, I will not be covering the techniques of spinal sonography, and I will not be dwelling into in detail the published evidence. However, I will provide you the pearls, tips, and tricks as to how you could perform real-time ultrasound-guided central neuroaxial blocks. If you are interested to learn more about the applications of ultrasound in different areas of the spine, then I welcome you to visit ISSPS TV on YouTube, where you will find most of these details. You can also find most of these details about the techniques of spinal sonography and injection techniques in these books that we have published from our institution. A lot of credit should go to Dr. Thomas Grau from Germany, whose pioneering work in the 90s actually has set the stage to our application of ultrasound for central neuroaxial blocks. Today it is possible to perform spinal sonography of the lumbar spine. You can not only perform a transverse scan, but also a sagittal scan through which the neuroaxis can be visualized, and thereby interventions like epidural and spinals can be performed. You can use ultrasound also as a pre-procedural tool, that is to preview the anatomy and then perform the intervention like you'd normally do with a landmark technique. Or you could use it in real time to perform or assist the central neuroaxial blocks, which I will be focusing mostly during my presentation. Currently, unfortunately, due to some good work by various researchers around the world, there is a wealth of evidence now to show that when ultrasound is used as a pre-procedural tool, that is to preview the anatomy before you perform a landmark-based technique, it is beneficial. It helps you accurately identify the midline. You can accurately identify a given lumbar intervertebral space. You can detect vertebral rotational defects like in scoliosis, and thereby you can predict technical ease or difficulty of an intervention. You can also determine the optimal site and trajectory for needle insertion and predict the depth to the epidural space or the thecal sac. All this information, when put together with your landmark-based technique, improves first-pass success and reduces technical difficulties. In the obstetric field, the use of ultrasound as a pre-procedural tool also has been shown to decrease bloody tap and postpartum headaches and backache. However, there are also data that shows that when you compare conventional landmark-based technique versus pre-procedural ultrasound for neuroaxial in non-obstetric patient, it is not of much benefit. In fact, it does not improve the first-pass success rate and increases the total time taken for the intervention. So when it comes to real-time ultrasound-guided central neuroaxial blocks, our research group described ultrasound-guided epidural injection by a single operator in 2009, whereby we perform not only epidurals but also combined spinal epidural injections. However, it is fair to say that a review of the literature indicates that there is a paucity of data on this topic of real-time ultrasound guidance, and it is not as popular as ultrasound-guided peripheral nerve blocks. Several different techniques have been described in the literature, but there are no optimal techniques described to date. So why is real-time central neuroaxial blocks not popular? I think the very basic answer is that anatomical landmark-based techniques enjoys a high success rate up to 97 to 98%. It has a low failure rate and also results in low rates of complications, including dural puncture. There are also data now suggesting that real-time ultrasound guidance is more difficult than landmark-based techniques. But I'd urge you caution when interpreting such data, because the individuals who perform these blocks may not be considered experts because they only had a minimum of performing 10 prior blocks before the study was conducted. So the question is, what will you do if you had a patient like so, a patient with scoliosis presenting for fracture hip? Would you turn your back on these patients? Fortunately, with the use of ultrasound today, it is possible to deliver neuroaxial blocks in this group of patients, which would have otherwise been considered impossible in the past or even a relative contraindication. This is surprising given that many of these patients are known to develop restrictive lung disease and cor pulmonale, and without surgery, the outcome is quite obviously well known. So in order to really understand real-time ultrasound-guided central neuroaxial block, we need to look into some of the basic considerations. First is ultrasound equipment. Today, ultrasound equipment is available in different shapes and sizes, of different quality, but when it comes to central neuroaxial blocks and difficult imaging, I have no doubt in my mind that it is these card-based systems that deliver the best quality images when the chips are down and you have a difficult patient. When you look at transducers, because the spine is a deep structure, we usually low-frequency ultrasound. However, it is important to note that these transducers are relatively heavy in weight. Therefore, it is paramount to train your non-dominant hand that will be holding the transducer. So hand grip strength is vital. So as you can see here, I always recommend that you use a medicine ball to train your non-dominant hand like so. Ultrasound gel is a no-no when it comes to neuroaxial blocks, because if any of this ultrasound gel enters the neuraxis, then it may induce an inflammatory response akin to possibly meningitis or arachnoiditis, and therefore, as this animal study shows. So therefore, we use normal saline to moisten the skin as an alternative coupling agent. Position and ergonomics are vital for success when you perform real-time ultrasound-guided central neuraxial blocks. As you can see here to the image to your right, you can see a patient is in the left lateral decubitus position. I am a right-handed operator, so I hold the transducer with my left hand, and the scan is now being performed from the non-dependent side. So if you can see that this is the non-dependent side, and this would be the dependent side. You get a paramedian sagittal oblique view, which you can see to the sonogram to your left, where you can see the lamina, the interlaminar view with the thecal sac. You can also perform neuraxial blocks with the patient in the lateral position with the needle inserted from the non-dependent side, and I will be alluding to this shortly. Whenever feasible, it should always be performed. Central neuraxial blocks with ultrasound should be performed in the sitting position because it may offer advantages when it comes to CSF efflux. However, it may not be possible in every individual, particularly patients with trauma. So when you have a patient in the left lateral decubitus position, you can now then have a non-dependent side and a dependent side through which you can perform the scan or the needle insertion. Now, this is a cartoon to show you that we're performing a paramedian sagittal scan from the non-dependent side with an in-plane insertion from the caudal end of the transducer. Like so, you can see the Tuhi needle is being introduced from the caudal end of the transducer, with the transducer acquiring a paramedian sagittal oblique view. When you see it in real time, you should see the needle approaching like so from a caudal to cranial end. It's inserted in plane, and through the interlaminar view, the needle is introduced into the ligamentum flavum if you're doing an epidural, and then you elicit loss of resistance, or you advance the needle through and through until it enters the thecal sac for a spinal injection. It is possible to insert the needle with the scan performed from the dependent side, as you can see in this image. However, this produces some issues with ergonomics because visualizing the needle becomes more difficult. In contrast, if you are a right-handed individual and you have a patient in the right lateral decubitus position, this produces ergonomic difficulties, and now you have to hold the transducer with your right hand and insert the needle in plane from the non-dependent side using your left hand. So I think this results in a situation which becomes a recipe for failure. So the take-home message is that whenever you can, you should position the patient in the lateral position, depending on your handedness. So if you're a right-handed individual, place them in the left lateral position. This will allow you to perform the intervention with optimal dexterity, and vice versa if you are a left-handed individual. In order to overcome this issue of dexterity and handedness, the researchers from Wuhan in China have described the transverse interspinous view. As you can see on the sonogram to your left, it is an interspinous view, and the needle is inserted in plane, but from the non-dependent side, as you can see here. Now this way, whether you're a right-handed or a left-handed individual, it does not matter, and you can perform the intervention. As you can see here, the operator is holding the transducer with his left hand, and with his right hand, the needle is introduced from the non-dependent side, and thereby the needle appears like so in the sonogram. Using this transverse approach, Dr. Liu and his colleagues have reported a success rate of about 95% with a median needle insertion of 3, a range from 1 to 6. The sitting position is quite useful, and particularly when you have individuals with large body habitus, where you can sit them up and perform either a transverse or a sagittal, paramedian sagittal scan, and depending on the optimal window that you get, you perform the intervention either from using the sagittal or the transverse view. Needless to say, maintaining strict aseptic precaution is fundamental to real-time ultrasound guidance. Since you are now handling transducers, needles, catheters, I think fully gloved and gowned with a proper transducer cover that would give you optimal imaging is important. As you can see here, the patient has been scrubbed and prepared, and the needle is being inserted. Tuhi needle is being inserted from the non-dependent side in an in-plane approach. We find these plastic drapes very useful because you can not only see through them to see all the landmarks that you have marked in your pre-interventional scan, but also to maintain sterility and asepsis. Okay, then how do we perform ultrasound-guided epidural catheterization, or maybe it would be better to say, how do we use ultrasound-assisted epidural catheterization? As you can see here, the patient has been positioned in the left lateral position. To your left is the head, and to your right is the back, the bottom. And here you can see a paramedian sagittal oblique scan is being performed with the Tuhi needle inserted from the non-dependent side in plane by a single operator. The target window is the paramedian sagittal oblique view to the interlaminar spaces, where you can see the lamina with the ligamentum flavum through the acoustic window, and the needle is then inserted in plane from a caudocranial direction, like so that you can see the needle advanced to the plane until you can see it engaged within the ligamentum flavum. Once the needle is engaged in the ligamentum flavum, the stylet is removed. And in this study, we use a spring-loaded syringe because we are performing by a single operator. This circumvents the need for a third hand, whereby you can attach the saline-primed spring-loaded syringe onto the tuhi needle and then gently advance it till you get a visual sense of seeing the plunger advance forward with ejection of the saline into the epidural space. So there is a visual detection of loss of resistance. However, I don't recommend that you should go shopping to go buy these syringes, because I think the prudent approach would be to visualize the anatomy, insert the needle to the interlamellar space till you see the needle engage with the ligamentum flavum, and then place the transducer down and use your normal loss of resistance technique with saline or air that you use to elicit the loss of resistance. Today, ultrasound technology is not advanced enough to tell you that the needle tip has now entered the epidural space. So we still have to rely on loss of resistance technique to identify the epidural space. However, if you use ultrasound in about 50% of individuals, we found that you could see sonographic changes within the neuroaxis at the moment of truth. Here you can see in this sonogram, which will continue to loop, is that you can see there is anterior displacement of the dura, this compression of the thecal sac, and widening of the epidural space with the saline. Note that we were using a spring-loaded syringe, so there's no way you can stop injecting the 2 to 3 mils of saline that was within the syringe. So these are sonographic signs that confirm that your needle has indeed entered the epidural space, with widening of the epidural space, compression of the thecal sac, and increased echogenicity of the posterior dura is another important finding that you see. But however, I'd like you to note here that when you do a CSE, you can see that the needle is now being inserted from the non-dependent side, and it's about 3 to 4 centimeters. The hub of the needle is about 3 to 4 centimeters from the thecal sac. With the thecal sac having been compressed, it's not uncommon that you see dry taps with combined spinal epidurals. So one has to be vigilant about this phenomenon, that there is actually compression of the thecal sac at the site of where you locate the epidural space. If you don't wait long enough, that's about 30 seconds or so, because the CSF is a dynamic circulation. The thecal sac returns to its normal self. Then if you immediately advance the spinal needle, like in this case, needle through needle technique, then dry taps are not uncommon. We then inject the local anesthetic through the spinal needle. The spinal needle is removed and the epidural space is catheterized and the catheter secured as you would do in your normal practice. So how can we use ultrasound to perform real-time spinal injections? The principle is the same. You perform a paramedian sagittal scan with an in-plane needle insertion from the non-dependent side, as you will see here. You will see the needle as you advance the needle, you can see the needle advance to the interlamellar space, whereby you can see it reach the ligamentum flavum. The resolution is often not as good every time. So therefore, in this case, we are doing a spinal, so you then advance it through the dura until you can see the needle within the thecal sac. Sure, the gold standard and endpoint would be to see the efflux of CSF. But as I alluded to before, that the hub of the needle is now about 3 to 4 centimeters above the thecal sac. So if the CSF pressures are low, it's not uncommon to see very slow efflux of CSF or even dry taps. As you can see here, I've spoken for almost 30 to 40 seconds, and that's when you start to see the CSF, the first drop of CSF emerge from the hub of the needle. In a retrospective review of our real-time ultrasound-guided spinal injections with the technique described, we found that the incidence of dry tap was about 10%. This is with confirmed sonographic confirmation of the needle within the thecal sac. There's also a slow CSF efflux, sometimes even up to 3 minutes, in about 14 to 15% of individuals. So therefore, it gives a combined incidence that in 1 in 4 real-time spinal injections, you will have some issues with CSF efflux. If you're familiar with this phenomenon, which until recently we were not, then you can take countermeasures to try and prevent this. Although there are different measures that have been described in the literature, like abdominal compression, cough maneuvers, I'm not so sure that this would be desirable in an operative environment. So therefore, as I said, perform the intervention in the sitting position when you can with in-plane needle insertion. Like you see here, the patient has been positioned in the sitting position. Paramedian sagittal oblique scan has been performed. Aseptic precautions, both the operator and the patient. The needle is now inserted from the dependent side. Usually, because we are using 25-gauge spinal needles, we usually use an introducer needle. The introducer needle can also act as a aiming device or as a guide. And once your needle is aimed towards the interlamellar space, then you can advance the spinal needle, and then you can see the efflux of CSF, which is the endpoint. And in this case, you will see that this is a 25-gauge spinal needle, and despite the patient in the sitting position, you can see that CSF efflux can still be relatively slow. So the moral of the story is that you have to be patient when you do spinal injections. Now, I'm not sure we are so patient when we do spinals with patients using landmarks. We always expect the CSF to gush out like they do in obstetric patients. May not always be the case. So in order to circumvent dry taps during real-time ultrasound-guided spinal injections, we have described a transverse in-plane dependent technique recently, which goes by the acronym TIPD. This is a case series that's published in the ANA practice. You can get more details there. It basically involves performing a transverse interspinous scan whereby the needle is introduced from the dependent side. As you can see in this sonogram that there is no acoustic shadow of the spinous process, and here you can see the posterior dura and the thecal sac with the pulsating chorda equina within the thecal sac. Unlike the non-dependent needle insertion by the researchers from Wuhan in China to improve dexterity, in our case the needle is inserted from the dependent side, as you can see here. Now, a tip for you is that when you perform these scans, you have to offset the transducer slightly towards the midline so that the needle is not introduced from too far laterally. This is an important step because otherwise, if the needle comes from too far lateral, you risk contacting the articular processes of the vertebra. So as you can see here, this is the line that describes where the needle should be inserted, and the midline is somewhere along this part of the back here. This is the head end, and this is the back of the patient, the bottom of the patient. So the needle is introduced from the dependent side, initially an introducer needle, and once the introducer needle has been aimed towards the ligament flavum or the interspinous space, we then insert the spinal needle, 25 gauge spinal needle through it. As you can see here in this video, the needle is introduced from the dependent side. You can see it's entering the, this is indeed the introducer needle. You can see, as you see here, on a spine model, you can see how the needle is introduced. And once the needle is, the introducer needle is aimed towards the thecal sac, we then insert the spinal needle through it. As you will see here in this repeating video, this is the introducer being introduced. And then through the introducer, we will introduce a 25 gauge spinal needle that you just see emerging now. And then this is advanced towards the thecal sac to puncture the dura. In many cases, you'll often see this dural tenting that we often read in textbooks, but we really don't know what it means. This is the dural tenting that you will often see when you puncture the dura. We've had success of 97% with a CSF efflux time of about 22 seconds in an average in our cohort of patients. More recently, the spinous process laminar view has been described. And these researchers from Ireland, Switzerland, and Toronto, led by Dr. Conroy, have described this spinous process laminar view, whereby you can see here the transducer is placed with the patient in the sitting position or in the lateral position. You can place the transducer like so, obliquely across the spinous process and the lamina of the dependent on the lower vertebra, so much so that you are scanning through both the spinous, interspinous, and the interlaminar spaces to produce this beautiful wide ultrasound window. The more I use this, I find that whenever this window is visible in the individual, may not always be the case. I prefer to use this window to perform most of my spinals. Currently, you can see here, this is the spinous process that you can see, the cranial spinous process of the vertebra above, and this is the lamina of the vertebra below. And through this acoustic window, we can see the posterior dura, the anterior complex, and the thecal sac within the spinal canal. The needle is introduced like so, in plane from the dependent side. And here you can see the introducer needle is being introduced to the spinous process lamina. This star is over the lamina, and you can see the introducer needle again act like an like a aiming device. And then through the introducer, we insert the 25 gauge spinal needle to see dural tenting, and that is ultrasound guided, real-time ultrasound guided spinal injection. The Taylor technique has also been described. The Taylor technique utilizes the gap between the L5 and S1 or the lumbosacral junction to perform spinal injections. It's mostly used in patients with difficult backs. It's interesting that the Taylor technique was described as early as 1940s, but it's rarely used for central neuroaxial blocks. Also, more importantly, it's important to understand that whenever individuals for scoliosis have hardware inserted like Harrington rods, it rarely gets placed on the lumbosacral junction for functional reasons. So therefore, the L5S1 can be an important portal through which you can perform neuroaxial blocks in difficult patients. It basically involves performing a paramedian sagittal scan with low frequency transducer like so, until you see the large flat surface of the sacrum, followed cranially by the first lamina. Of course, therefore, in individuals with lumbarization or sacralization, there is some inaccuracy in the identification of the L5S1, but when it comes to performing spinal injection, this inaccuracy is probably not so relevant. As you can see here, we're performing a paramedian sagittal oblique view. You can see this is cranial and to your left, and this is caudal to your right. You can see the sacrum. You can see some artifact because there is some fibrous tissue from previous surgery on the back, and then you can see lamina. And then you can, within the acoustic window, you can see this large thecal sac with a large interlaminar space. So don't ignore the L5S1 as an important route through which you can perform spinal injection. As you can see here in this video, you can see the L5 lumbosacral junction in a patient with ankylosing spondylitis, where the needle is inserted in plane and it's being introduced to the L5S1 into the thecal sac. In conclusion, today it is feasible to perform ultrasound imaging of the lumbar spine. It can be used as a pre-interventional tool, that is, you preview the spinal anatomy, get your relevant information, and perform the normal landmark-based technique. And it has been shown to improve outcomes. Real-time ultrasound-guided spinals and epidurals can also be performed, but current evidence indicates that there is a paucity of data and is not as popular as peripheral nerve blocks, using ultrasound-guided peripheral nerve blocks. However, when it comes to central neuroaxial blocks in patients with difficult spine, then real-time ultrasound guidance, in my view, is the only way out. So if you want to become experienced in performing neuroaxial blocks in difficult patients, then it is imperative that you should gain this experience in normal individuals. Also, in institutions that train residents and trainees fellows to perform neuroaxial blocks, I think it should form an integral part of the training program. Certainly, there's a need for more research before it can become a mainstream, or it can be adopted as a mainstream tool for central neuroaxial blocks. Thank you for your attention.